Thanks everyone for being here and being on time. Um, Isabel or Danielle from HCPF, can you just let me know when all of the right folks from the HCPF side have joined us? We do still have some others joining, so I'm happy to give it a minute if we need more time. Oh, I just saw a thumbs up and then it went away.
We can let you know. I think the main person we're waiting for is Hannah Hall.
Okay, great. Danielle, I still don't see Hannah. I don't know if you're able to.
Kristen, are you guys prepared to go without Hannah, or do you need to wait for her?
Yeah, I think we have we have an ongoing DOC meeting at this time. So I think Hannah was going to stay there and I'm going to present to y'all.
Oh, okay, great. Well, then in that case, let's just get the party started. Hi everyone, Katie first from CCI staff. I know for our county commissioners and oftentimes our sheriffs and our jail staffs as well, this issue of Medicaid coverage for those county jail inmates comes up a lot and is a big burden sometimes on your county budget and has come up before with CCI as a legislative priority. Unfortunately, that is still the federal policy, and our friends at NACO are working, I know, diligently on that. But there have been some federal waivers and other federal changes that are going on that I know HCPF, our friends at Healthcare Policy and Financing, are working on and exploring waivers on. So I have just asked them with those very wide parameters to come and speak to us about what are those things, what are the status of those things, and maybe we can find some ways we can be helpful and partner moving forward. So with that, Kristen, I'll turn it over to you. Do you need screen share a bit? Okay.
Yes. Yes, please.
Make you a host. And then you
Okay,
should
you are a host now.
that.
So fast. All right, presentation one. Nope, that's not the one I want. CCI. All right, so let me get this in presentation mode. All right, everybody can see just okay? Big blue screen, big white letters? Okay, fantastic. All right, so I'm Kristen Bates. For those of you who don't know me, I am the director of our Healthcare Policy and Financing Office of Behavioral Health Initiatives and Coverage. I'm here with my colleague, Chris Underwood. Chris, would you like to introduce yourself?
Hello, I'm Chris Underwood. I'm our Chief Administrative Officer for the department. I work on the department's strategic projects, and I'm helping Kristen, Adela, and team out on our 1115 waiver submissions and helping set up the operations behind that.
Wonderful. Thank you, Chris. All right, so today what we're going to talk about is, I know some of you are really familiar with this, but I am going to do just a little bit of level setting on overview of waivers and the criminal justice policy. We're going to talk a little bit about the goals and components of our current and future state waiver and criminal justice policies, the role of the jails, and some timelines for y'all. I'm going to probably ask that I'm probably not going to answer questions during the first 5 slides, but then the last 5 slides, which are all about kind of like the jails and engagement, those will be, you know, if you guys have questions, please raise your hand and I'm happy to answer it. And then at the end, I have some discussion questions for our county partners. All right, so what is a waiver? The 1115 demonstration waiver, 1115 is just the section of the Social Security Administration law that this is under, but basically what we're talking about here is Medicaid is a state-federal partnership in which our federal partners set rules and minimum standards about when they will and will not give us a federal match. This really, in many ways, dictates how we're able to implement the Medicaid program. And what a demonstration waiver is an opportunity for states to say, listen, if you let us waive these federal rules that you have set for us that allow us to have more flexibility, cover new populations, generally it's access, expansion, and access. And we can show that it doesn't cost you any more money, then we can retain these expanded and more flexible benefits. A demonstration waiver lasts for 5 years, but you can renew them as many times as you'd like. They are regulatory, so they can change based on administration. And you can amend a waiver once you get it. So you can say, oh, I wanted to do it this way. We want to add more to it. That's what we're doing now. Right now, the way that we pay for substance use treatment in a residential setting in Colorado is through a waiver. One of the federal rules that we have is that Medicaid will not, federal Medicaid will not provide reimbursement for services that happen inside a Institute for Mental Disease, the IMD waiver. You guys have probably heard of this. So we have an existing waiver, and what we're doing right now is we're making amendments to add additional policy benefits into those waivers. And in order to do that, we're going to have to get federal approval every time we make a change. So I want to show you this just to show you that criminal justice reentry is part of our larger strategy. And so there are a lot of other waiver conversations happening that are around housing, continuous coverage, even like I said, IMDs and mental health, where we've applied for to cover mental health services for longer than 15 days in Colorado. So we have a multiple different sets of submissions. We have multiple different processes and procedures that we're following here. The ones that are really important to you all are, first off, we've submitted our first criminal justice reentry waiver for, that was submitted in 2024 in April. So just 3 months ago. And for that one, we've asked for express permission to start in the Department of Corrections. And we have technically said we are going to be expanding this into jails. So we are requesting that they approve our goal to expand into jails. However, we need them to approve that amendment before we can make any additional changes. So the point is, we can't amend an active amendment. It's too many amendments. So what we need to do is wait until that is finalized, and that's going to play into our timeline later. So you can see here that the additional jail populations, most likely we're going to be applying for so that we can start in the statutory goal of July 2026. Here's our waiver amendment that we submitted in April. You can see there are 4 parts to it, one of them being the criminal justice services in Department of Corrections, and I didn't mean to exclude Division of Youth Services. One of the reasons that we split these out is it had to do with the finance and operations and the contracting. We have one contract with the DOC, one contract with the Department of Human Services, and that's all we need to do for our readiness surveys, for our implementation. For the jail implementation, applying these services to jails, we have to have a readiness survey and a contract and a implementation plan that includes every single jail. And those contracts are going to have to be jail specific. So it is going to take us more time than it will for some of our state-run institutions. This is the one that we're working on right now. We're about to submit it in about a month, less than a month. And this is housing supports, nutrition supports. Again, lots of exciting things coming out of these waiver opportunities. This was directed to us through legislation this year through House Bill 1322. And it covers some things that I think are also important to, even though it's not specific to criminal justice, we all know that housing supports and nutrition supports are really important to keep people healthy and well, especially people who have ongoing behavioral health needs. So what is in our re-entry waiver services right now? So like I said, these are guidelines that our federal partners give us. We couldn't just pick any service we want. We couldn't say, here are the 5 most important health conditions or types of services that we want. They gave us very strict guidance and said, if you do it this way, then we will approve it. Now, in that other, in this one, you can see we can look at additional coverage, additional populations. We can look at that after 2026. But what our federal partners have said very clearly is, if you do it this exact way, you will get what you are asking for. And that is where we are going to start. After that, you start to learn from other states. So what that includes right now in our waiver that we have submitted for DOC that we will be applying for jails as well is 90 days prior to release is the timeline. All Medicaid eligible individuals, which is by our calculations about 80% of people in jail, in any local jail, DOC or DYS setting, is covered for the following services: medication-assisted treatment, care coordination and physical and behavioral health assessments, and a 30-day supply of prescription medications upon their release. You all know, hopefully, maybe you do, maybe you don't. When we looked at how long people stay in jails in Colorado, it's about 17 days on average for a misdemeanor and 45 days for a felony. That doesn't mean that we are covering everyone. It can only be 90 days prior to release that we are authorized to cover this. And that's because the goals are really about transitions of care, keeping people healthy as they go from the incarcerated state to the community. But we all know that if we're covering 90 days, a lot of people aren't even in jail for 90 days. So we would be covering the entirety of that individual stay. So again, those medication-assisted treatments, that includes long-acting injectables, all different types, all the different types of FDA-approved medication-assisted treatment, buprenorphine, naltrexone, and methadone. And then it also covers that kind of physical behavioral health assessment and care coordination. Those things are together because the goal is that you get assessed for your needs and then you get appointments on the other side, so that care coordination is really related to those assessments. But those assessments also include, again, that behavioral health assessment. I know a lot of you have, for example, JBBS, jail-based behavioral health services in your jails. For those jails, the assessment that's done by the JBBS that says, do you have a mental health or a substance use need, that would be included. So those screeners, as well as those physical health assessments. And then the 30-day supply the goal is you walk out with a brown paper bag. You don't have to go. It's not that you just get your services covered if you go pick them up from a pharmacy. It's that you walk away with those so that you don't have some kind of destabilizing issue related to lack of medications. What are the goals of this? Again, back to why are we doing all of this? These are the express goals stated in the federal policy documentation, which is that we are connecting people to better care to get better health outcomes. And the research that's in some of the guidance that our federal partners have given us is very thorough and very compelling. It really highlights that connection between maintaining health and maintaining access to substance use and mental health treatment specifically, and reducing rearrests, recidivism, health disparities, hospitalization. And then overdose is a really big one. You all know the stats on this. It's like 120 times higher rate of overdose and overdose death following an incarceration.
Hey, Kristen, I
yes,
am
Katie.
so sorry to interrupt you. I think when I made you host to share your screen, I lost my ability to let people in from the waiting room. Are you able to reassign me, hopefully, maybe, just so it's one
I
less thing you have
can
to worry
admit
about?
everyone.
Or just admit everyone? That's perfect.
Okay.
Sorry about that.
Oh, no, it's okay. Oh my gosh, I'm so sorry. Poor things. Waiting out in the cold.
These Zoom protocols are getting tricky.
Okay, and then I'll just keep an eye out. It did give me a little flash. I just assumed somebody else could do it. So if somebody else comes in, I will let them in.
Thank you so much.
All right, so the next one is expanding total health, total access to physical and behavioral health care. Again, having a navigator, I don't know about y'all. Sometimes I feel like I could use these services myself, right? Like I would love it if somebody could just help me get an appointment with a specialist, help me get an appointment when it's time. So these care navigation services are really helpful in increasing access to care. And then this last one is really what we have identified as well. To be very clear, in 1115, this waiver specifically says any cost savings that you have from this program to the state, they can't be used to build bridges and roads. Like you have to use them to help improve the population health of this same group. People who have been incarcerated, people who are incarcerated, people who are at risk of being incarcerated. Now, I would argue that anybody with a mental health or a substance use disorder or somebody who is unhoused is at risk of being incarcerated. So those are some of the programs that any cost savings from this program, we are going to be, as a state, required to ensure that funding is supporting that same population. All right, and again, those three benefits that we're talking about here, we're not talking about the entirety of somebody's health care. It's the assessments, the care coordination, the MAT, and the meds upon release. All right, so any questions at this point? Okay, great. So there's a couple things that we're going to need from the jails that would like to participate. Now, the way that we've written it so far, when we ask for this inclusion, is that we would include, we would make it available to all jails. I think that when I talk to the County Sheriff's Association, when I talk to a lot of the county partners, there's this it's a very palpable, very real, very loud commitment. We are going to do this. I want you to understand that there might be some circumstances in which the volume and the required effort might not add up. We are not forcing jails to do this. This is an optional benefit that jails can participate in, but there might be reasons that are very specific to a very specific jail, very specific county, that would prevent them or make it unattractive for them to participate. And we just want you to know, our goal is to make this as easy for you as possible, to create an implementation that helps this work and doesn't make it difficult. But we also understand if that's the case, and we are not requiring, or jails will in no way be retaliated against or punished for not participating in this. It is it is the decision of our local partners. So I want to make that very clear. However, if you want to participate, then we do get to say very specifically what that looks like. So for participating jails, what we will need is a partnership to be in the readiness assessment. That basically is like, do you provide the services that we're highlighting here? Do you have the ability to enroll people in Medicaid in partnership with your county? And are you able to maintain those kind of quality oversight standards that are required for Medicaid? We worked with the counties to make sure that we didn't have specific additional licensing required for jails or oversight. That was important to us to make this easy. However, we are still learning about I'm even going to get the acronym wrong. It's like the Corrections Health Agency National. Anyone help me out here? They're having a big conference in Vegas this year.
National Association of Correctional Healthcare.
National Association of Correctional Healthcare. So what we haven't done and what we will need to do together is look at what does the National Association require? What does Medicaid require? Is there daylight between those two things? And what does that look like? So when we talk about a readiness assessment, most likely what that's going to look like is looking at your policies and procedures. We'll have some technical assistance to help you create strong policies and procedures here. But and then, you know, making sure we have enrollment as a Medicaid provider. This is not an optional thing. Anybody that is paid by Medicaid must be a Medicaid enrolled provider. Now that might be the jail, or if you subcontract to a provider, it might be that provider that's enrolled, right? So there's a lot of different ways that this could look, but we're going to try to be as flexible as possible on this, but there will be some readiness standards. Some other considerations that we wanted to highlight is one of the pieces of the legislation requires that the jails demonstrate a commitment to diversion or deflection efforts. So most likely, in addition to the readiness assessment, which is federally required, this will be something we'll also add to that as a state requirement. What are your diversion or deflection efforts? That might be, we participate in state-run efforts. We partner with our court services. That could look like a lot of things, but that was a requirement of the bill. I think that, you know, a consideration why we think that you would like this, and I think this is based on basically what I've heard from jails and counties, it's going to really help with that as a long-term funding solution to comply with the standard that you must offer MAT in jails, right? This is supposed to be really helping that option. And then, so that's the positive. The challenge is there's almost always going to be additional administrative action that's going to be required. You know, we've started visiting jails and we already are hearing from some of our kind of correctional service partners that even the jail-based medical health and behavioral health agencies, they don't bill the same way, they don't bill to insurance the same way that, you know, somebody on the outside would in the community. So I think it's important to understand that this is where it's going to be really essential that we work together to create some level setting, some understanding. What is the additional cost? What are the changes to policies and procedure? And what is your potential return on investment for that? So I think that that is the investment that we are expecting you all to have to make. If you participate in this program, it is going to require change, right? And that change is going to hopefully, again, we're going to make that as easy as possible. We're going to try to do this as at the minimum standards possible, but there are certain standards that are unchangeable, unshakable, and that we have to ensure are happening. So this is just an overview of kind of what it might look like if we are paying for services in a jail. What Medicaid would do is we would receive a federal match. Say you have a $100 encounter. So it's somebody's behavioral health assessment, physical health assessment, and their induction onto medication-assisted treatment. For ease of calculations, we're going to say this costs the jail $100 to complete. So there's a federal match of that $100, and that match is determined by that person. So it's somewhere between 50 and 90%. We make an average, we're estimating an average of about 77% of every dollar, 77 cents on the dollar, we'll get a federal match. That means the jail portion still exists, right? The jail portion is $23. So that $23 is the jail's portion, whether they pay that they would pay the provider, and the federal match would come through Medicaid to either the jail or the provider. I want to recognize, though, that there's also a lot of non-covered services that are going to happen. That is, services your jails are providing to people who are not eligible for Medicaid, services that are outside of that, kind of those three things, you know, lab, radiology. Actually, the medications that somebody's getting while they're in jail are actually not covered unless they're MAT medications, right? So your total program costs are going to be deferred, and they're going to benefit from this light blue federal match, but it's not going to wipe out the costs of your healthcare, right? Again, trying to be clear on the expectations and level setting. I think that there's a huge opportunity, 77%, right? But that 77% only applies in certain circumstances. So let's talk about the timeline, back to the timeline that we kind of started with here. We are required by April 1st, 2025. So I don't know how many months that is, 4, 5, 9 months from now, to request federal authority for reentry services for jails. And by 2026, if we have the federal authority, then we will start this process. Between now and July 1st, 2026, we need to be working as if the deadline is yesterday, right? This is going to take some time. We need to be visiting jails. Jails are going to have to, we're going to have to identify what our implementation, what some of that implementation might look like. We're going to learn from our DOC partners during this time, but we're going to need continuous engagement with you all as we plan for this second round of our second actual amendment proposal that we're submitting to the feds. This April 1st date is a little bit challenging for us because during our renewal, so remember I said we have a waiver, we're amending that waiver, and then we're going to get a new waiver in 2026. That's going to be a new 5 years. During the renewal timeline, there's a blackout period. So I don't know if April is going to be, you know, we've already technically requested federal authority here to start reentry services in jails, but that July 1, 2026 date is going to be the really key date that's going to be important for you all for implementation. Okay. So we have, we went down to Pueblo. We've got meetings. We've got, oh, we already toured. Did we already tour all of these? I feel like there's one.
Yes. Denver, we still have left.
Denver, we had to reschedule. That's right. But we did go to Washington, Jackson, and Pueblo counties to see kind of different types of jails and different experiences in different counties. We are going to be meeting regularly with the jail-based behavioral health services staff, and we're going to be connecting with the Sheriff's Association and I can't remember what CJA stands for, but they're, Meredith, do you remember? Or county partners, anyone remember CJA?
Colorado Justice Association? Maybe?
The jail association.
Jail Association, there we go. So we are working with both of those groups. And then I wanted to just say, Katie, thank you so much for reaching out proactively. We would love to continue this conversation, maybe a quarterly update, quarterly engagement with you all, and then meetings as needed to talk a little bit more about what this looks like. So are there any requests, suggestions, or additional ways that you all would recommend we work with you, our county partners, I don't know if they're your employees, your partners, your other county jail partners? Any advice or recommendations for us on how to make sure that all of this stuff that we're trying to do, that we don't want this to come to somebody's jail and they'll say, what is this plan? I have not been engaged. I don't know what you're talking about. I'm not convinced this is the right thing for me. How do we make sure that we get everybody this information in front of most people? And how do we make sure that we're engaging in a meaningful way?
Kristen, I'll just say from the association perspective, I think a quarterly, some sort of standing meeting makes a lot of sense. And I was even thinking while we were talking here, maybe doing a similar presentation, at least during the CCI conference, would be helpful. because what I also don't want to happen is a sheriff is really engaged with you all, and by no means, please don't take offense to this, sheriff and jail staff friends, but to do all of this work with you all and then come to the commissioners and say, hey, we're doing all of this and now we need 1 FTE and we have to amend this contract, and the commissioners have no idea. So it'd be helpful for them to kind of be a part of this at the forefront. But I know we've got some commissioners on the call, so I'd encourage you all to also jump off of mute and share what might be most helpful.
Detention chiefs.
Yeah.
In Gilpin County.
Yeah, so I know that information between all the different levels within the sheriff's office doesn't always flow to maybe the person you want it to. So like in our small county, we have a detention chief who oversees the jail, detentions, those staff. And so he's been engaged on these topics with me and others. But like if this went to the patrol chief, it may not trickle over. So just specifically identifying in the jail who the chief contact is. They may not be a chief per se, but in our case, it is that way.
Sandy, that is such a great point. And Hannah, if you could mark that down, even the sheriffs will say this, right? They'll say, I might not be the right person because I'm actually not sitting day to day with the inmates and I'm not an expert on eligibility. I've got a guy for that, right? So I think what that looks like, Hannah, is we need to make sure we have our county list of contacts to include both the sheriff as well as the preferred point of contact for that county, if it's not the sheriff. And I think a lot of, like, we presented at the Sheriff's Association and they were like, you actually want to talk to the undersheriffs. That's the main person like that you should talk to. So I think there are a lot of folks who have that similar effort, and I don't, yeah, so I think that that's really helpful. Okay, and I'm hearing that Jameson Brown is a key person. He is the president of the Colorado Jail Association. We had some of their key folks down in Pueblo also say that this was a really great group because it's kind of also those multiple stakeholders. It's not just the sheriffs. So that's really helpful. Okay, and then Nora from Summit County says that she has a strong relationship with the clinical case managers located in the jail who does a lot of the process incarcerated persons. So Hannah, as we look at the readiness assessment, prior to that, maybe we also want to have an understanding of some of the clinical staff that work directly in jail. I know this is something that's highly variable across different counties. Some have clinical staff full-time. Some do a subcontract to specifically a criminal justice health agency. Some of them work with like a community health agency. So for example, if you are a jail and you are, let's see, like down in Pueblo, I know they have specifically like a criminal justice correctional organization that they subcontract with. And then they also have some JVBS services that are funded through BHA, but like the person works for the county. So there's a county staff, there's subcontracted staff that invoice. And then there are certain circumstances where they also work with their opioid treatment program, which is where the methadone is, where they get for their methadone programs. So in those cases, the way that you bill for services for those three individuals might be different. So you might have a single jail with procedures that are saying, okay, for any covered services that are paid for by jail staff, procedure A. For any services that are delivered by our subcontracted correctional health organization, procedure B. And then anybody that we, specialty care that we subcontract with, here's procedure C. I did want to recognize, I'm going to go back up to the top. We have a couple of comments and I think I can hold on just a second, just get to these discussion questions so we can throw those up there and start going through some of these comments. Commissioner Rowland, thank you. From Mesa County, most jail inmates are less than 90 days. Can we make sure their Medicaid is not turned off? So the answer to this is actually the program by which we pause somebody's Medicaid eligibility. So we don't terminate them, we suspend it. That's actually a requirement of the 1115 waiver. So what we do is we suspend their, straight Medicaid, standard Medicaid benefit. We create this special benefit for them that's while they're in jail. And then we turn back on the big Medicaid after they leave. So it is not an option for us to not turn it off. It's actually a requirement. So this is something that states have to demonstrate they can do before they can even be considered for a waiver.
Thank you.
Yeah, thank you. Let's see. I also see, and I don't know, Nora, if you are a commissioner or not, Commissioner Blackman, maybe, we applied for and were awarded a grant to cover Medicaid, a study for Medicaid for incarcerated persons and the process surrounding this and applying for Medicaid. How will all of this affect a study that we have a vendor conduct if under that awarded grant? Honestly, I think that is so fantastic that you have a grant to cover this. We would love, love, love to have just like an interview with you or your vendor to talk about what you all are finding, but nothing about having a grant would preclude you from being able to receive funding for this. Now, if you are using that grant to, for example, get paid for medication-assisted treatment, you can't then bill it to Medicaid. But apart from that, I don't see any conflict.
Thank you for that. So we were awarded that grant. We're still in the process of obtaining it. And I was just wondering if it was going to affect it, but we're really excited to go forward with it and collaborating and maybe even sharing what we find. Right now, it's just going to be a study on the actual process, maybe automating it and see what's required, sharing that out. And yeah, basically that's where we're at right now.
Yeah, please let us know how that goes over time. All right, we have Laura from El Paso County. Because most people in jail are pre-sentence, we do not know their release date. Will we be able to bill retroactively within the 90 days if someone is released? I anticipate the answer to this question is yes. And I think when I talk to I know when I talk to other states, this is one of the big challenges that they see. Not knowing your release date is a really big part of determining somebody from that date of release being essential to their services. So one of the options that some states do is they allow for you to bill when you know somebody's release date. You can start billing Medicaid as soon as you can, but we might have to have some kind of timeliness policy in which if you bill for somebody 120 days from the date of service, usually we ask you to do it, I think, within 90 days, we might have some kind of timeliness of filing. Oh, we have 365 days of timely filing. Melissa, thank you. But we might have to make that 365 days plus 90, so I don't know what that looks like, but that's definitely going to be, the expectation, is that a lot of times if you don't know the release date, then you might have to bill retroactively. And the idea of estimating a release date, that is very common also, having an estimated release date. I think the only challenge is if that release date ends up being, so say you start January 1st and you estimate somebody's release date is January 31st. So you could bill, that entire month, but they don't actually end up getting released because, I don't know, new charges, they pick up charges while they're there, they get in a fight, they pick up a new charge, and they don't end up getting released until November. If you have already charged and been paid for that January cost, you will owe that back to the state, right? Because those will be unallowed federal dollars and those would be subject to clawbacks. So there's going to have to be, that's kind of like why we need some of this reporting and the standard expectations of what the release date is, and a requirement that that release date be included in all claims. And yeah, we could do an estimated, but there would be a risk for the jail. And so I think that that's something that we would want to talk through with you all. What's preferred? Is it up to jail, or do we make a statewide decision on it? We don't know yet. All right, let's ask this first question for as one prompt. What do you all see for what are some of the challenges that you all think that would be important for us to focus on? We kind of talked about getting the right person, getting the right point of contact. Release dates is one of them. What are some other challenges you anticipate in this space?
Kristen, I have a question.
Yes, sir.
So community corrections kind of falls in between jails and prisons, and it's kind of, as they call it, a halfway house. That has been problematic in the Colorado justice system as it relates to service or benefits. Could you speak a little bit more about what the plans are as we move forward with community corrections and treatment programs that are necessary to curb our recidivism and problems that we're facing?
So this policy is very specific to being in the carceral setting, which would not include the halfway house. Ideally, this would help if somebody is going into one of those step down residential facilities. It would help to think about, is there somebody from the halfway house that's already doing in-reach to the person? Or is this an extension that would help somebody so that when they arrive, they've already got their recovery plan in place. They've already got, like their medication assisted treatment, so that day one, they're going to go be able to get access to it, and that they have their transportation set up. So I think that that's kind of the goal, is that it improves that transition period. For community corrections, what does it look like for in-reach right now?
Well, Kristen, I just want to jump in there. We've made a policy change several years ago that people in community corrections are eligible for full Medicaid. So when you're in community corrections, it's a pre-parole kind of situation. There are a few people who get sentenced directly to it, but those folks are on Medicaid. So yes. I'm not quite sure, quite honestly, from DOC to community corrections, I don't know what the pre-release services actually look like, because they're not really, it's a weird area.
Mm-hmm.
Oh, it is a weird area, oftentimes overlooked. We have about 3,000 people in community corrections, and in terms of Medicaid, we have a problem because Medicaid sees people who are incarcerated as not having a substance use problem or a substance use disorder because they've been incarcerated for 3 years. Well, we all know that the very first thing that they need in transition is to get back to that addiction issue and address that. Becomes more problematic for them individually.
Yeah, I think this is an issue with people in hospitals and jails. So you go in for an overdose, you're in the hospital for 6 weeks. You go in jail, you're in jail for 6 weeks, and they're like, congratulations, you haven't used drugs in 6 weeks. You're doing so well. You don't need treatment. So right. I hear what you're saying. I think that probably is not something that this policy is going to fix. I think that's more about the assessment process overall for substance use. So I do think that this is something that, Hannah, we want to bring in Jennifer Holcomb on, and Melissa, if you want to take that as a follow-up item. Yeah,
Mhm.
sorry, just 1 second.
Yeah,
I appreciate you just putting that on your radar.
yeah, and Timothy, I don't know if you had gotten any of this information before, but the ASAM criteria that is used to kind of determine that level of care, they are coming out right now for the first time with some set of recommendations specifically to the justice involved population. So I'm excited to see how that plays out. And I think the intention there is to address some of the concerns you just described, where folks are kind of artificially being assessed lower than their true need. And then if we can use that updated criteria, I think that'll help.
No, that's great. I do want to be clear, well, JBBS services are specific to, I think, people who've been there like at least 30 days, and I think it's supposed to be post adjudication. This is for all populations. So if you are incarcerated, you are eligible. So there's not any, the adjudication is not relevant to your eligibility status. I can absolutely share the deck. I don't know that we recorded this meeting, Katie.
I did record it, Nora. So I will make sure probably next week I'll get the deck from Kristen and it'll be in the county ECL newsletter, and I'll make sure it gets over to Lexi and our CHSDA friends to get in their newsletter as well.
Gonna say I better get a Friday update. I read those every Friday.
Can't beat it.
Hannah, you can send this PDF of this deck over to Katie, please. Great. All right, let's talk a little bit about, I had asked if there are existing reentry programs. I hear Summit County has, you'll have some new things. Are any of you all working with some reentry programs that you think are effective, that would be worth replicating? Are there learnings that we have in county specific areas that might be best applied to multiple different jails or to the larger state? Oh man, I hate silence. It's uncomfortable. It's so hard for me to sit here and wait. So if there are anything that you all can think of, please let me know. Oh, Heather, Larimer County.
Hi, Kristen. Good to see you.
Good to see you too.
So two things I can think of for Larimer County, and I don't know if we have anyone from our jail, but we have what's called the Stone Soup Project. So it brings together a collaborative of partners that are service providers to help connect individuals leaving the jail with resources. And then the result of one of the HCPF innovation grants from, I think, 10 years ago, we still have 2 to 3 eligibility staff from Human Services that help serve our criminal justice campus directly from their location, helping people connect with services so that they don't have to come to our Human Services office.
That is great. And I love the name, the Stone Soup Program. Hannah, maybe we can do if we haven't done a tour of Larimer County, we might want to. I haven't seen the new facility. This may be a little bit.
I put my information in the chat, so you can send me an email and I'll fill you in. This is Stacy Schaefer from Larimer County.
Thank you so much, Stacy. Okay.
We have a program in Mesa County. It's called our MAC team, stands for Multi-Agency Collaboration, and we contract with agencies that already provide case management, and they work with people coming in and out of our jails. So I don't know if it would be considered a reentry program. We kind of see it as that. They work closely with the transition team, but they'll pick them up when they're released, make sure they get to their court dates, make sure they have a place to go and land, and help them get a job and all those kinds of things. So I think Lisa's on the call and she could answer questions if you guys have any about that.
Thank you, Commissioner. I mean, I hope you all aren't sleeping on this care coordination piece. It seems like a small element, right? Care coordination seems like, oh, well, that's the little part of the larger treatment. Care coordination is pretty much what people need when they're in this transition space. So to the extent that your jails and counties already have, through your human services office, through your jails office, those transition teams, those coordinating teams, I think that there are exceptions, as in we can't cover like specifically the eligibility folks, because we pay for them differently. But if there are people who are providing care coordination, that is one of those services that you should be able to be receiving reimbursement for. And the complexities that the people who are in these jail situations, I mean, I don't know if you all have seen examples of this close up, but 35-year-olds with psychotic disorders that have never had a psychiatrist their entire life. You know, I mean, the amount of digging out of areas where people have had delayed care, lack of access to care. Maybe they're just new to the state, right? Maybe they're new to the area, but there are so many places where it's unbelievable that the person has gone on so much without help. And once you start to say, what is it that you need? They need a village, right? So there's a lot of that care coordination, and we anticipate this is going to be a significant part of the cost. Now, the other big thing I want to highlight too, when we estimated the cost, I know trying to make sure that we had access to all the different kinds of medications was a question we'd had before. Long-term, long-acting injectables are covered, and there's not any, we have to offer them all equally. So there's not like prior authorization for some and not for others, right? So we know that's a really big expense. And so it is going to be part of this. And I think that the criminal justice population is the right one to really look at prioritization. So we could reimburse for that. But what we probably couldn't do, what I think we've heard from some people, is kind of pay up front so that you can purchase those services. It always is going to be a reimbursement model, not a grant model. All right, so Lisa Mills has shared with us that MAC team information for follow-up. And then we also have Sarah San Castillo Jones. And what county is this for the JBBS program administrator for San Castillo? Castillo County?
That might.
Or
Oh,
Douglas.
Douglas.
I don't know.
Douglas County.
Okay.
Oh, the person just has a name that also is a county. Okay. All right, thank you. Boulder County also has an established medications for opioid use disorder program. Melanie Judson, RN, is the contact, and they work closely with the community providers on transitions of care. So the other thing that we wanted to highlight is not everybody has to start at the same time. You know, I anticipate that the counties that have really well-established JBBS and really well-established programs in which they're providing care in jails and they have larger populations probably are going to have an easier time completing like a readiness survey, or already having established procedures that they have for some of this. Obviously, every jail has some kind of procedures around MAT, which is, I think, going to put us, that's a huge foundational piece of this. And it's going to be really, really helpful in that readiness survey. So I do think that the state is in a really good place for this. And I know a lot of you have feelings about that policy, so I won't dig in that wound any further. But this might be a silver lining, is that it helps us be very ready for this policy that's going to help us pay for that. And I just realized all these people are giving their emails not for us, but for you, Katie, to get this information. Okay.
I'm tracking them. Don't worry.
Okay, so we don't have to email everybody who's in their email here.
Nope, I will send a group email if you put your email in
Thank
the chat with the recording and the slide deck once I've got it.
But I do think, Hannah, we do want to follow up with Mesa County on their MAC team, as Lisa has shared. And potentially with Douglas County's reintegration team. And with Summit County. So I think those are, and with Larimer County. So those are the areas where I do see some follow-up. Okay, any other questions?
Kristen, something I was thinking about as you were speaking is it might also be the opioid regional councils might also be a really great group to engage with, just because it does bring together a really nice group of commissioners, sheriffs, but also substance use treatment providers and kind of that related subset. And if you need connected with the Attorney General's office hosts some regular standing calls with those regional councils, and I know they do a conference once or twice a year. That's probably a good avenue to get connected with them, but also worth kind of engaging with and maybe bringing some of this information to. And there might be some opportunities to partner with some of those dollars there if the region is willing. Yeah,
That is a great point.
We're
yeah,
singing from the same songbook.
Hannah, let's do a follow-up with Jamie Feld and talk to her about getting on that, because I sit on the state committee, but we need to get on that regional. We need to talk with the regional leads. Because I think the other thing is when it comes to the regional dollars, some of the things that are priorities in that Schedule A are really about setting up systems for long-term support for folks. And so I think that if it comes to, for example, getting a vendor to help write some of your policies and procedures or complete your readiness assessment, like, hey, listen, we could do this in a year, or you can give us $50,000 and we could do it in 4 months, right? I mean, I think that if I'm a county, that's definitely what I'm thinking about, is like, what is it that Schedule A allowable, activities for my regional opioid committee? What are some that apply directly here? I know that, for example, like back to the grants question, with Department of Corrections, they received an Attorney General's grant to cover some of their MAT costs. And I imagine some of you are receiving some grants or other funds for your MAT costs. Again, that would not prohibit you from participating in this or from us doing a readiness assessment. It would just be really essential that no services are being charged to both a Medicaid cost and to a philanthropy grant, right? All right, looks like Laura from El Paso County has raised her hand.
Yeah, so if a jail does participate in this and we can now bill for the approved Medicaid services, do we also then have the ability to suspend Medicaid for people who are active prior to coming in the jail and then restart them within that 30 days of them leaving the jail, or does not fall under this?
No, actually our suspend function allows us to put this, I'm going to call it a mini benefit, right? So you don't want to turn on their Medicaid while they're still in jail because they don't have a full Medicaid benefit. They have a partial benefit, just MAT, assessments, care coordination, and those last 30 days of Medicaid. 30 days of medication upon release, not in their last 30 days. Upon their release, they walk out with a bag of 30 days of medications. So those are the only things that can be covered. Because of the way that our billing and our systems work, it's essential that you do not turn on somebody's big Medicaid before they are released. So your procedures to suspend and unsuspend Medicaid should not change with this program. What's going to change is what's in their suspended benefit. So they're going to have a suspended benefit that actually allows you to bill for certain services.
I think though, Kristen, I want to be clear that they may not have a process to get people on Medicaid so they could bill us. So we may have to make sure that you guys are coordinating well with your county Department of Human Services to say, hey, you know, Chris showed up in my jail today. He's going to be here. So we want to provide Matt services and things like that, but he's not on Medicaid. So you're going to have to work with your county partners to get Chris on Medicaid, and then you can bill for the services.
I think that even billing for services is going to be the really complicated piece.
It
too.
is, and we're making this sound very easy, and I've been thinking it through my head here, like, how are we going to make this work? And it is complicated. And we just left DOC, a meeting with DOC an hour ago, and it's complicated for them. They don't have a billing agent. They don't have the software. They don't have coders. So how are we going to tackle this? And then how are we making, we also have to remember this has to be budget neutral to the state. So the state isn't going to put in the state share like a normal Medicaid payment. The counties are going to have to put that in, and we're going to have to think through the complexities of how that works and how we document that for CMS. We have a similar program. It's called the school-based program that Medicaid runs that people may know of. And it's got some complexities to it that we may have to work through with our county jails also. So I've just been thinking about those as you've been doing your presentation, Kristen. So we're going to have to do some internal work and really come back and talk about the detailed operations, because that's where it gets weedy, right? In the operations piece, if you want to sign up to do this, the upfront cost to get us there. And maybe there's an opportunity here for people to begin to think about, should there be, if some jails want to get together and have a statewide vendor do some of this service for them in the billing, that may be a better way to leverage this, especially if you don't have the infrastructure already set up to do that. So those are all the things we're going to have to work through over the next year or so to get answers to that, so we can lay it out for you of here's all the steps, and the nuances to actually, it's just not providing services, it's the billing part too.
Right.
Mm-hmm.
And this is, just one example of, having worked with a nurse at one of the jails, and she said, I've been doing this for 30 years and I've never billed insurance. So even the correctional facility specialty healthcare providers, they're going to be learning this. I will tell you, because this is happening nationally. So WellPath, and I can't remember all their other names, Geo something, all of those specialty providers, they're a lot of them national companies, and they're going to learn how to do this and they're going to help. But I think that's the question. Are we paying the jails who then pay their subcontractors? Are we paying the subcontractors directly, but just a partial payment, and then the jail is paying them the rest of their payment? Or are we paying, for example, a community health provider that's already a Medicaid enrolled person who are, a federally qualified health center, a CMHC, something like that? So I think that's where I was saying you might have different billing procedures depending on who's providing who's the actual rendering provider, all of which is going to be complicated. Because it's not something that's done right now. We can't do invoices. We can't, that's not going to be an option for us to do a monthly invoice that says services, right? We need to know information for each encounter. So again, this is where I'm suggesting that it be a serious consideration for jails. This is not, I love that you all are starting from yes. I feel like people are coming to this and starting from yes. But the considerations about what changes need to happen, how many people are getting these 3 services in your jail, and how much you're going to get for it, are all what has to happen when you are determining what is my return on investment for this plan. And again, this is maybe where some technical assistance from your, having funding for technical assistance from some of your opioid treatment settlement funding might be a good option. Or from other, I know that there are BJA grants, and I know that there are statewide attorney general's grants, and I know that the Behavioral Health Administration has grants. So to the extent that any of those are an option, I think it's going to be important to start thinking about this in your planning for the coming years and how ready you want to be.
love to perhaps put some of our human services directors or staff maybe on the spot, because I do think like right now, there's, you know, getting people enrolled when they come into jail if they're not. So we're able to start services as soon as that release date is determined. How is like, who's doing that well, or are there best practices? And then also like human service directors, you know, what does that communication look like now, but also looking forward, knowing all of these things are coming with your friends over across the way at the jail?
So for us, it's a pretty manual process. Ruby Hornback is the clinical case manager over at the Summit County Jail. And the way we have it set up is she has the incarcerated person actually fill out the application. She'll attach it to an email, and then she sends it to our department email that's monitored daily. And then it gets put into the queue to be processed. And then she will add herself, with the permission of the person applying, she will add herself as the authorized representative so she can correspond with us. And then she just consistently follows up as far as the correspondences that are generated after the case and the application has been processed and authorized. And then those are sent to her. They can be sent either via email or through mail. And then she will send us the release date, and then that will be processed on the case as well. So it's pretty manual at this point. Nothing's automated. And that's what the grant's going to cover, is the study for that. And that's the piece that I'm looking at. I'm not familiar with anything that's being spoken about here, but it is a learning process for me. But really our process is really manual at this time. And because that email inbox is monitored, we're able to process every single application that she sends to us, whether that person already has Medicaid or they don't have Medicaid. And that's how we take care of it.
And that's really important too, is that it's not just, that it's not just for people who are already on Medicaid who are being suspended, but it's also identifying people who are, you know, my favorite acronym, eligible but not enrolled, the EB&E folks. We want to get them in there, get them services, make sure that their coverage is on, so that as soon as they get out, they can have those services connected. Heather?
So I think I'm probably not going to share anything that all of you don't know, but I think the challenge is just a lack of resources. When there are so many individuals eligible for Medicaid, we had to make a philosophical change in our business process when we implemented from the HCPF grant to prioritize this population with the 2 or 3 staff that we have, and move that work out of the bigger pile of new applications that we receive. And so it's just hard to not be able to do that, to be able to prioritize all of the eligible populations equally. But we've worked through it, and I think we've seen some great success. I would say the really crucial pieces that we've identified, one, when the HCPF grant funding ran out, we were able to absorb them then into our bigger county administration allocation, which was helpful because now the individuals that we have assigned to our criminal justice locations are able to screen individuals for all of the benefits, not just Medicaid. So they're looking to see, is the individual also eligible for SNAP or other benefits, because we're paying for it with broader funding. So I think that's a significant improvement. And just one of the constraints we had under the grant. But the other piece that I think has been really crucial, and there are several of my criminal justice partners from Larimer County on here who could probably even speak to this better, but it's being able to have dedicated human services staff available at their locations to develop those relationships with the case managers and the other staff in their departments, because the eligibility and just the process of applying or trying to tackle, you know, if you already have Medicaid, why there's a disruption or whatever the challenge might be, is so complicated that often you need to rely on those relationships to walk through the scenario and be able to really dig in and understand what the issue is. And having that relationship so that there's a face with the name and knowing, okay, there are 2 human services staff who I can reach out to and we can walk through the case scenario, I think is really crucial. And I think it's a different, we've talked about how do we expand, and thinking about how we assign human services staff in the jail. I love working in criminal justice settings. When I was a social worker, working in prisons and jails was my favorite location to work with clients, but it's a different mindset. It is a different, when you're recruiting and trying to identify staff that's a good fit for, it's not a good fit for everybody. And so trying to identify the right staffing, so that it is a good fit and it's successful and we're able to serve those individuals as they need to be served, I think is another challenge.
So maybe this is something we need to really consider, is putting together some of these best practices and known challenges. Because I think that as people are going to create their policies, it's important to highlight some key elements. So there's kind of like there's the compliance, and then there's the regulatory kind of, this is the minimum. But maybe this is something where you all have some shared resources together to say, these are some really key elements there. And if there's any way that we can help support that work through shared documentation or shared resources, or keeping things in a place where people are able to learn from each other, that would be great.
I do think, Kristen, it would be really helpful. I think the technical assistance that is very often needed to learn how to bill Medicaid, to figure out the documentation that's needed, working through that process. We have another staff member who's developed that as her expertise. And so she's often working alongside other community partners to learn that. But I've heard you say it might not be worth the return on investment for everyone. It is a heavy lift. And I think having a good handful of those technical experts from HCPF that can provide that technical assistance as jails are getting up to speed, I think that could be really helpful.
Yeah, I'm hearing Gilpin County, sharing staff across smaller agencies, Delta County saying, hey, listen, let's talk about what a smaller staff looks like for this, and what the options are. I will also say, my screaming pug will also say, sorry about that. I will also say one of the things that we had gotten questions about before is like, well, what if I don't bill for everybody, or what if I can't get them assessed, or what if they don't get their medications? Again, every time that the jail decides to bill, like, you have to meet certain criteria as an organization. But if there are people who don't get through the process, if you have somebody who comes in actively intoxicated and is there for 3 days, and maybe they got an assessment while they were there, and you don't get to bill for it, you just don't bill for it. That's okay. Like, every dollar that you bill is a dollar less off of your total amount. So it's like, some people might say, hey, listen, we're going to shoot for 50% of our MAT to be covered, right? Like, we're going to, even if 80% are eligible, it really is an opportunity for federal funding and reimbursement. But also, perfection is not required, right? Like, and this is different than it is for like a federally qualified health center. You can't have somebody who comes into an FQHC, who comes into, like Mountain Family Services and says like, oh, I just didn't get to billing. I just didn't get around to billing for them. I just didn't get around to getting their information. It's a little bit more flexible in a jail setting, because basically you're already serving all of these folks. You're already doing a lot of this work. And to the extent that you can get people medication, increase their access to services, increase the reimbursement to support the healthcare that's needed in a carceral setting, that's where we're going here, right? But nobody's going to all of a sudden be like, oh, you should operate like a hospital, because jail is not a hospital and a jail is not a health clinic, right? We understand that. Unfortunately, our federal partners understand that. Okay. I know we have about 15 minutes left. If you all have any other questions, you can send them to Hannah. Hannah, I didn't even have you introduce yourself. Can you just introduce yourself real quick?
Hello, I'm Hannah. I work for HCPF in the Behavioral Health Initiatives and Coverage Office under the wonderful Kristen Bates, who we've been hearing from. I am our criminal justice policy advisor, and have been helping project lead on our Medicaid reentry services. So I'm very, very excited about this work and these new opportunities. And I have a long list of action items for myself. So if you're on this call, I wouldn't be surprised if you get an email from me soon.
So Hannah is our face of this work. She is the specialist. This is her entire job. And we ask nothing else of her. No, just kidding. I try not to ask anything else of Hannah. She's just so good at her job. It's hard. So this is Hannah's whole job though. She is our criminal justice specialist advisor. So she is your lead. Meredith Davis, Melissa Edelman, Chris Underwood, Kristen Bates, all of us can be a resource for you. But I know if you can't have a single point of contact, it's easier. Single point of contact is Miss Hannah Hall for this work. Katie, we had discussed potentially having ongoing meetings as a next step from here. Can we make that decision over email and maybe a follow-up call with us and some administrative people so we don't hold 40 very important and incredible county leaders up any longer?
Yes, I would love that. So
Okay.
yeah, everybody look forward to more. Thanks to everyone who shared their email address. So once I get this Zoom recording downloaded and uploaded, look for that in your inbox or in your newsletter, the same place you found the notice for this meeting. And just want to say thank you, HCPF team, for taking the time to share all of this with us and all of your hard work on this. And looks like a lot more to come that I think we're all looking forward to.
It's an exciting space and we are really looking forward to working with you all on it. All right, have a wonderful day, everybody. Stay cool. Take care.
Thank you. You too.
Thank you.
Bye.